and make it quicker. I'm Katy, co-founder of Joy Women's Wellness, Joy and Blokes. I founded this company 5 years ago based on my own real struggles to find help and feel better. And I know there's so many women out there that are still struggling to find answers. And so at Joy and Blokes, we really care about helping provide that access and that education. So that we can thrive through these stages. So thank you for being here. And Dr. Newson, what a wonderful advocate for women you are. We are so excited to hear from you today and appreciate you spending some time because I know you're a very busy woman. So please feel free. Sorry about the technical difficulty, everyone, and go ahead and start again.
Oh, thank you. Well, as I was saying before, and I will say it again, my mission really is to improve the global health of women, which is no mean feat. But I feel very strongly if women have the right knowledge, then they can make the right choices that are right for them about their health, including their hormone health. And the problem is we're going back in time. It's harder than ever before in your country, in my country, for women to be listened to, acknowledged, believed, and also prescribed the hormone treatment they both want and need. So I feel the only way we can change it is working together and enable women to really speak up for themselves. So a lot of my work is really about choice. So it's great to be here. I'm hoping, I'm not sure, is my screen should be shared already. So I'm hoping you can see the first can you see the first screen, the first slide of my, is it shared or not? No. Okay, let me try again. Right.
There we go.
Hopefully, can you see the first slide now?
I can, yeah. Yes, we can.
Perfect. So it's great to have a positive title, actually. Hormones and happiness. Hormones are often something that people are scared of, and actually, hormones are something we produce ourselves. And so, really, in this presentation, I really want people to think differently about hormones. I want just to open your minds and think in different ways, and there'll be some time for some questions at the end. So, before I start, really, it's important for me to be clear that I don't have any financial conflicts in that I don't work with any pharmaceutical companies. I don't endorse any products or brands because my work's really impartial. It comes from a wealth of scientific knowledge and evidence, but also from a huge amount of clinical experience too. I founded Newson Clinic 8 years ago, really to help women who are underserved by our National Health Service. And hopefully, you all subscribe to my podcast, which comes out twice a week. And hopefully, you all download Balance app. And if you don't, I urge you to do it because there's a huge amount of information in there. It's a different organization to the clinic. It's really just about empowering people. And I've got some great content and really incredible people I work with on that. I also founded Newson Education, which is an enabling healthcare professionals all over the world to access information and an education program called Confidence in Hormones. I do work with the government on their menopause task force, and I have one conflict in that I do take hormone treatments and I've taken them for several years now, and if I wasn't taking them, I wouldn't be happily married. I wouldn't have such a close relationship with my three daughters, and I would have also given up my job. And, my brain is the most important asset that I have. And without it, I was really struggling. But even now, I struggle to receive the dose and type of hormones I need from my NHS GP. And the inequality of care is what drives me to work so hard. So this is just a gloating slide to make you feel very jealous because this is my clinic in Stratford-upon-Avon that we rent from the council. It's a beautiful Grade 2 listed building, and Stratford-upon-Avon is the birthplace of Shakespeare, but we're making it the hormone capital of the world. And this is just a spiral staircase that goes up to our clinical rooms. So I'm going to just talk about two patients because I think it's really important to really think about different types of women. Obviously, I see thousands of women in the clinic of all ages, and they obviously this person didn't look like this. Her name wasn't Laura, but all the other facts were completely accurate. So she came to see me in the clinic a year or so ago, and she'd had 10 years of symptoms. She had given up her job. She was working as a teacher, but she found that she was really tired. She couldn't remember things. She had a lot of time off sick. She was really, impacting on her colleagues and the students. So she gave up her job. She said she couldn't sleep. Sometimes she'd sleep on the bathroom floor to cool down because she was so hot at night. She said she had terrible memory, brain fog. She had a lot of joint pains, so she stopped exercising. She had back-to-back migraines, a lot of recurrent urinary tract infections as well. She'd had palpitations. She'd had some dry, itchy skin as well, and she'd had a lot of mouth problems as well, burning, sore mouth too. So she saw lots of different doctors, and she said she went with many different doctors with her symptoms, and not one of them made any connection. They kept treating each of her organs in silo, and she didn't know either. She had no idea that her symptoms were related to a change in hormone levels. So, as millions of women are really, it's all about a symptom, making a diagnosis, and then a treatment. So, she had painkillers, but she also had anti-epilepsy drugs prescribed off license for her migraines. She had sleeping tablets, she had indigestion tablets, she had antidepressants, she had a lot of cystitis and urinary tract infections, so antibiotics. She had statins because her cholesterol was raised, and she also had blood pressure treatment. So she was on a lot of medication. But the saddest thing is, she said to me that I was broken, lost, and confused. She'd hated what she'd become, and she'd even considered ending it all because she didn't see a future in how she was going to improve. She said it was the worst time of her life. She tried therapy as well, and that didn't help. And she said the gaslighting from doctors was awful. A lot of people said it was in her head, there was nothing else they could do. And one doctor very unhelpfully asked her, what about doing more yoga? Would that help? And as you'll see at the end, I'm very passionate about yoga, but I hate to tell you, yoga is not going to replace your missing hormones. So I will come to her at the end. Now, the other person I want to talk about is someone who's younger, actually. This is a lady called Mary, who was 22 when I saw her. She's a student at Edinburgh University studying geography. She told me her period started age 13, very common age for people to start, but she said her puberty was dreadful. Like a lot of people, it was completely normalized, but she said she was very scared of her own emotions, especially those days before her periods. She said it was like Jekyll and Hyde, like black and white. She became very irritable, angry, short-tempered, but also very low mood, very reduced self-esteem, not very much confidence, very anxious. And this all started at school, in secondary school. She went to a big school. There was lots of stuff going on, and she felt really inadequate. So she started drinking with some of her friends because she wanted to just escape some of her feelings. So when she came to see me, for 3 years, she'd had a lot worse symptoms. Her sleep was really intermittent. Anxiety was off the scale. She said the low mood was bad, but she started to get some intrusive thoughts, which was scaring her. Concentration, memory, terrible, and her confidence was really bad. But when I took a history, and I take a careful history from my patients, she was very clear that these symptoms were really bad the 7 to 10 days before her periods. And she said the few days after her period, she felt great. But she was very scared to talk about these symptoms because she knew she'd be judged or misjudged from people. So she'd kept a lot of it into herself. She had seen a doctor who'd referred her to the mental health team. She was diagnosed with depression and a possible borderline personality disorder. She had told someone about some of these thoughts, and they said, you've probably got a psychosis, maybe bipolar. And she was also on a long waiting list for an assessment for ADHD. So she'd been prescribed antidepressants. Someone had added quetiapine, which is an antipsychotic, for these intrusive thoughts. And then more recently, she said she had seen psychiatrists and they wanted to prescribe lithium for her. I just want to remind you, this is a 22-year-old girl who's been prescribed these medications. But like I said to you, when I see people, I take a really careful history. But we do a symptom questionnaire, which is on the Balance app. So it doesn't just ask about mental health symptoms, and I'm a general physician. So I asked her about other symptoms. And she said, oh, yes, I do, but no one's ever asked me because I don't think they're connected. And I said, well, let's go through them. So she had joint pains, abdominal pains, cystitis, skin, and her skin was dry and itchy. She had night sweats. She put on some weight, and her periods were very heavy. And these physical symptoms were worse the days before her period. And she said, I really find it very difficult to perform my work, can't concentrate, can't focus. And now things were getting worse. And a lot of it, she was getting side effects from the medication as well. And she said, I want to hide away. When she asked the psychiatrist and her GP, her family physician, what else she could do, they said, well, you're under quite a lot of stress. You've got your finals coming up, and it's probably all in your head. Really not helpful for a 22-year-old who's on heavy duty medication. So I'm going to come back to those two patients at the end and tell you what I did for them. And hopefully you'll see there is a happy ending to this. But if you think about menopause, I find this word really awful actually, and I would like to bin it from people's vocabulary because if you look it up, it means a year since a woman's last menstrual period. Now, for me as a doctor, I have a real issue with that because I want to make a diagnosis today when someone comes to see me, not in a year's time. So it's not very helpful. But also, there's lots of people that don't have periods. A lot of people have had a hysterectomy or might have contraception, meaning they don't have periods. So it feels a bit weird doing that. Some people talk about it being the end of a woman's reproductive age, but I have an issue with that as well because for two reasons really. One is that we're not all about reproduction. And for some cultures and ethnicities, it's a real stigma if people aren't fertile. And a lot of women delay coming to get help because they don't want to be judged as being infertile. But secondly, it's not accurate. We know that about 1 in 30 women under the age of 40 have menopause at an early age. But those women, depending on the cause, of course, if they're given natural hormones, you can improve their fertility. So again, if young women stop coming because they think that they're unable to conceive, then it might delay them having, becoming pregnant. So it's wrong. And also, if we're just thinking about menopause, then what about other times of hormonal change, which in my mind are more significant as well? So PMS is premenstrual syndrome, PMDD, premenstrual dysphoric disorder, perimenopause, which is the time before periods stop and symptoms start, postnatal depression, also postnatal psychosis. So these are times of hormonal change. If we're only thinking about menopause and periods, we're missing millions of women who have hormonal changes. So I'm really shifting the way I think and talk and think about hormone changes rather than menopause or perimenopause or whatever. Because 100% of women have hormones that are changing, and the vast majority of us have symptoms related to these changing hormones. And globally, only a very small minority are given the right dose type and formulation of hormone to improve both their symptoms and future health. But hormones are chemical messengers. We produce them ourselves. They are made in different organs, they go into the bloodstream, and they affect every single cell in our body. And the problem with thinking about them being related to periods, people think they only affect our reproductive system, and of course they affect our womb, but they go into the blood and affect everywhere. So we've got these very simple posters, and I'm not going to read them out to you, but I've redone them just so people can think a bit more broadly about how estradiol, which is the positive anti-inflammatory type of estrogen, how it affects the brain, the skin, the bones, how it goes in every single organ, because when you understand how they work, without them, you can quickly understand why you're getting symptoms and health consequences without them. So we've done one on estradiol, progesterone, which is a really important hormone. Progesterone comes from cholesterol, and cholesterol forms progesterone, and then progesterone actually makes testosterone, which then makes estradiol. And progesterone also makes cortisol and cortisol. So cortisol is our stress hormone. Cortisone reduces inflammation. So the balance of those hormones is crucial. So progesterone is a really important hormone, and testosterone is the most biologically active hormone we have as women. And we make more testosterone than we do estradiol in our bodies when we're young. And again, it affects every organ, every cell in the body. So it's no surprise that when we don't have those hormones, or levels of hormones are fluctuating in our body, there's a myriad of symptoms that can occur. Yet if you ask people about menopause, they'll always talk about flushes and sweats, but they won't think about all the other symptoms. But we don't just get them in menopause. The symptoms that people get at other times of hormonal change, so women with premenstrual syndrome, PM and PMDD, premenstrual dysphoric disorder, when those hormones are fluctuating and changing before periods, it's exactly the same symptoms, and the same with postnatal depression and also perimenopause. So, the symptom questionnaire we have on Balance is a symptom questionnaire for people who are having hormone changes, not just menopause. And if we look at our data on Balance, we've got a massive amount of data, but people are monitoring their symptoms all the time. And what's interesting is the most severe symptoms are tiredness, reduced libido, tinnitus, that ringing in the ears, joint and muscle pains. And the most common are those affecting our brain. So the brain fog, anxiety, low mood, tiredness, memory problems. We need to be thinking about that because these are the symptoms that are affecting people. And this is looking at the symptoms of like 135 million logs. There's a lot of people that are monitoring their symptoms. And the top 10 common, top 10 severe, you can read them. I'm not going to read them out. But it's interesting that hot flushes just made the top 10 most common, but night sweats was 34. But they're not the most severe. I do see people that have drenching sweats or unable to regulate their temperature, but they're not the symptoms that are causing people to give up their jobs or affecting their ability to function. And so we need to be thinking more about general. But a lot of those symptoms, as you see, could be thought of as mental health symptoms or other causes. And so that's why it's important that everyone understands about hormones and what they do. So the symptom questionnaire that we give is the same as what's on Balance, and we've got over 80 questions and we've grouped them together to different types of symptoms. So it's easy for people to say whether they have none or extremely, and then we can monitor their progress. And you can download it with a QR code if you've got your phone on the screen, or you can just go to Balance app and just monitor your symptoms there. But this symptom is really interesting, actually. Not feeling like yourself or not recognizing yourself. There are some studies that show it's actually very specific and quite sensitive marker really for hormonal change. And if any of you are listening and you've had that, you'll know what I mean. A lot of us have had that where you just know that you need to be feeling differently and you don't, there's no other reason for it. And we see a lot of women who really improve when they have their hormones back, but especially this one symptom. So it's just something to really think about. I've said we get these hormonal changes throughout our menstrual cycle. And many of you will remember this chart from probably from when you were younger. In the middle of the cycle, there's a peak in estradiol and estrogen when we ovulate. And the second half of the cycle, we have more progesterone, which increases and decreases, and we get again another up and down of estradiol. Testosterone peaks when we ovulate. Testosterone is a very good hormone for fertility. But there's a real problem with this graph that really frustrates me, and I'll show you why. Because the progesterone is completely wrong scale. When you try and put it into the right scale, progesterone is so much higher than estradiol. And it's the progesterone that declines from being quite high to nothing before the periods can trigger symptoms. And some women, and we don't know why, but some women are very sensitive to those changing hormone levels, and they can get these physical and especially mental health symptoms. And these women who have extreme symptoms, we diagnose as premenstrual dysphoric disorder, PMDD. There's quite a lot of academic discussion, whether it's PMS or PMDD. As you might know, the psychiatrists seem to own PMDD and have made it a psychiatric criteria with DSM criteria. But actually, it doesn't really matter the label. We know it's due to a hormonal shift. And symptoms can be very extreme. This is a picture that one of my patients actually did for me. And it's really shocking because the days before her periods, all the symptoms on the left in black and white is what she was experiencing. And then her period will come, and the first few days of her new cycle, she would be feeling incredible. But then as she got older and her hormone levels were dropping, it was more that she was spending 3 weeks in the black area and 1 week in the red area with a rainbow. And the only thing her doctor was going to offer her was a hormone blocking drug because they said it's a hormone problem. Let's block your hormones. Thankfully, she didn't. And thankfully, she's now on natural hormones and she really is in the rainbow side most of her time. But it's very extreme. It's very black and white, these people. And they really find it very difficult. You can see why so many women are misdiagnosed with bipolar and mental health conditions. And what's really harrowing, if you see, look at some of the stats, 72%, and I read another paper recently, it was 84% have suicidal thoughts. Half of them at least will self-harm. 1 in 3 will attempt suicide, but hardly any of them will have hormones prescribed for them. Usually they're misdiagnosed as having a borderline personality disorder, mental health condition, and they're given psychiatric medication. So anyone that has those symptoms, we have to be thinking more about hormones. And then I've mentioned postnatal depression because we've known for decades that women have very high levels of hormones, especially progesterone in their body when they're pregnant. When the baby is born, our levels decline very quickly. And for those women who are often have a history of PMS, PMDD, they often have postnatal depression or psychosis. And I worry about it because of the risk of suicide. And suicide is still the leading cause of direct maternal death in the first year after having given birth. It's the same in the US as over here. 85,000 people a year in the UK alone have postnatal depression, and the majority of them will be given antidepressants and psychiatric medication because no one thinks about hormone. So we've known for decades that hormones can be very effective for these women, and you can still take natural hormones if you're breastfeeding as well. But one of the problems is that people think that the hormones are just something that happen in our reproductive system, which I've already told you they work in every cell, every tissue, organ in the body. But people also think they're made in our ovaries, which is true, but they're not all made in our ovaries. So, for example, about half of our testosterone is made in our ovaries. The rest is made in other tissues, including our adrenal glands, which are next to our kidneys, but also in our brain as well. And the brain is the most important organ in our body. And we have to be thinking differently about the role of hormones in the brain, especially when I tell you that those mental health symptoms are those that are the most common when we're thinking about hormonal changes in women. And so the hormones work to improve the connection between the nerves, the firing of those messengers that occur in the synaptic junctions. They help the whole brain to work in so many different ways. So these are very simple pictures that we've done. Estradiol, the good form of estrogen, is very anti-inflammatory. It helps with memory, it helps with concentration. Every single cell in our brain responds to estradiol. And also progesterone. So progesterone is not just for our wounds, like I've said, it really helps repair damaged brain tissue. It's very calming. It can help people sleep. It can help with mood as well. And the same testosterone, very important. It can help in all sorts of ways in the brain and body. But there are hormones, estrogen, progesterone, testosterone, work as neurotransmitters, so chemicals that allow the brain to signal a message from one area of the brain to another. And you will have heard of other neurotransmitters, I'm sure, like noradrenaline or norepinephrine, serotonin, dopamine. And this is a very simple diagram showing how the hormones work. But serotonin and noradrenaline both can increase impulse and anxiety, for example. They help with cognition, emotion, and mood, as does dopamine. So there's an overlap with our hormones. But what's very interesting is if you have low progesterone, estradiol, testosterone, you then get low noradrenaline, low serotonin, low dopamine. So this reward and pleasure that people get with dopamine often isn't there. So a lot of people feel flat and low in their mood. The serotonin, people feel less happy, low mood when it's not there. And the same with noradrenaline, they've got less energy, harder to concentrate because the progesterone, estradiol, testosterone will reduce the levels of those hormones in the brain. And we've got lots of other neurotransmitters that those hormones can change levels of. And, glutamate, acetylcholine, really important for our memory. So all of those, if they're not there in the right balance, they can really negatively affect our mental health and the way our brain functions. And one of the reasons I work so hard, I suppose, is that I worry a lot about the association between mental health and hormones, because a lot of women are suffering needlessly, like I say, with symptoms, but a lot of people are misdiagnosed with depression. People aren't thinking about the association with hormones and mental health. So this is putting people's lives at risk, literally, because we know suicide rates increase. They increase when we don't have our hormones, and we've known this for many, many years. And in fact, now in the UK, our suicide rate of women between the age of 50 and 54 is higher than it was in 1980. In 1980, about 40% of women were prescribed hormones. Now in our country, it's about 14%. It's lower in the States. Globally, it's about 5%. And so some of this is related to not having appropriate hormones. There are lots of other reasons why people have mental health conditions. But what scares me and worries me is that so many psychiatrists have no training in hormones in the brain. As you know, our heart's a very important organ. Cardiovascular disease is leading cause of death in women globally. So that's heart attacks, clots, strokes. And without those protective hormones, we have far higher risk, about 5 times higher risk of heart attacks and strokes and clots. And we need to be really mindful of that. The disease that I'm really scared about is osteoporosis. And this is a very dramatic picture, actually, that I got from a financial report from some of the bisphosphonate companies. The bisphosphonates are the drugs that people are prescribed for osteoporosis that make actually the bones very hard and more likely to fracture like glass. So it's quite an ironic picture because I don't want my spine to be like that. I don't mind. I don't want it to be too hard. And that's what the drugs actually do. So it was a bit ironic that they're promoting their drugs and they're showing how detrimental their drugs can be, because I want my bones to be really flexible, a bit like a plastic tumbler, so that if I fall, then there'll be some give in the bones and then I won't fracture. Because osteoporosis is very common. It affects 1 in 2 women who don't have hormones. And this osteoporosis of the spine can occur with these little fractures occurring, affecting people's posture. And then when you've got this curvature of the spine, they've got reduced lung capacity, so breathing problems. It can press on the digestive system, so harder to eat food. And obviously, mobility is a real problem. So we've got an increased risk of heart disease, we've got an increased risk of dementia, increased risk of osteoporosis when we don't have our hormones. But it gets more depressing. I'm not here to make you happy, I hate to tell you. But there's all these other diseases that increase when we don't have our hormones. And what's interesting is these are all diseases of aging. So the longer we're living, the more likely we are to have these diseases. But the longer we are without those 3 hormones, progesterone, estradiol, testosterone, the more likely we are to have those diseases as well. And when you think, well, what have they got in common? Like, what's multiple sclerosis, osteoporosis, rheumatoid arthritis, dementia? What have they got in common? Well, if you go back to basics, what they have got in common is that they're all inflammatory diseases. And I've written a whole chapter in my book about inflammation, because this is the most important cell when it comes to inflammation. It's the macrophage. And the macrophage helps reduce inflammation. It helps our immune system to work really well. And when we've got hormones of the right levels in our bloodstream, those macrophages work better. They can produce cytokines, chemicals that will repair damaged tissue and help keep us really, really healthy. A lot of you will have heard of our mitochondria. So mitochondria are the powerhouse of our cells. We've got trillions of them. And it's really important because we need the energy for our cells to work as well as possible. And on the surface of the mitochondria, we've got receptors for progesterone, estradiol, testosterone. So in the presence of those hormones, we've got less inflammation, our mitochondria work better. But if we don't have hormones, actually what happens is the macrophages work against us. We have more inflammation that can damage our tissue, and the macrophages don't work as well either. And all of this is increasing all these inflammatory conditions. So the metabolic diseases, cancers, autoimmune diseases, neurological diseases, cardiovascular diseases. The common denominator, if you like, is inflammation. And that can be caused by lots of things, including not eating well, drinking, alcohol, smoking, but the low levels of estradiol, progesterone, testosterone. And it's important because we're living so much longer as women that we need to try and stay healthy for as long as possible. And sadly, a lot of people aren't because of these diseases, meaning they're being medicalized. Lots of women now are being given 6, 7 different medications for all these different conditions that are related to their low hormones. But this is where the talk gets a bit better, you'll be pleased to know, and a bit happier, because there is treatment for these hormonal fluctuations. And the most important treatment, without a shadow of a doubt, is actually information. And that's why I launched Balance. I've been a medical writer for many years. If people are empowered with knowledge, then they can make choices about their treatment. So on the app, we've got lots of information. We're constantly adding new articles. We've got a symptom tracker that you can put those symptoms in and download a health report that you can share with your doctor. You can monitor how you are, so you can see how you are at different times of the month, for example, or you can see a snapshot of how you're feeling, and you can do a review of your treatment as well. If you've got in periods, obviously you can put those in as well. So really just trying to prepare for your consultation, because if you were going to a psychiatrist and you showed them that you also were having skin changes and urinary symptoms, then it's a really useful tool to say, well, could it be something that's happening throughout my body? Could it be something that's related to my hormones, rather than just focusing in on one area of the body? Obviously, being empowered with information, I've got information on my website, my podcasts, my social media is very busy, and my YouTubes as well. So, following that, reading and getting as much information. But the most important treatment for a hormonal deficiency or symptoms related to hormonal changes is obviously a hormone treatment. And evidence-based hormone treatment, in my mind, is a very exciting opportunity, because if we give them and prescribe hormones at the right time for women, it often gives them years of benefits from preventative health care, as well as helping them feel better. So we give hormones to improve the way women feel, which is not a bad thing to help women feel better, but it also reduces risk of all those diseases I've shown you, which is the most transformational thing ever in medicine, to be able to help people keep healthy. So there's different hormone treatments. I don't like the word HRT. I know you use MHT, but it's not really about menopause hormone treatment. And there are dozens of hormones. So calling it a hormone replacement doesn't really tell us what the hormone is, because we're replacing the missing hormones, but we have to be very specific. If someone's got progesterone deficiency for 4 days a month because they've got PMDD, they probably only need progesterone for 4 days a month to treat their PMDD. They might be like me and be deficient in all three hormones, in which case they need all three hormones coming back. And we mustn't forget vaginal hormones, which are essential really for the majority of women, because most of us have symptoms related to vaginal dryness, soreness, irritation, and also urinary tract symptoms. Like I say, they improve symptoms and future health. And this is where we need to be thinking differently, because everyone is scared about hormones for the wrong reasons, and I'll explain more in a minute. But we have to know that there are more risks of not taking hormone treatments than taking them. And that's really important for people to understand. Now, the best way to prescribe them is all about giving the right dose, the right type of hormone to the right person at the right time. Individualization of care is crucial. But we're talking about mental health today. So really, a lot of people say, well, what does HRT really help depression? There's loads of data out there. I'm not going to share much, but what I've shown you, this paper, because it's long, it's 25 years old. And it's a double-blinded, randomized, placebo-controlled study, which is like the best type of study you ever need. Giving patches or placebo, so dummy patch, for 12 weeks, women with depression. 68% of women had remission of their depression, compared to 20% in placebo. So the majority of women improved. Like, that is really important to think about. And then what about schizophrenia and depression? This again was a double-blind randomized control study. And there was an improvement in those who were on a slightly higher dose, actually, the 200 micrograms, probably because more was getting into their brain as well. This study is now 6 years old, but there's dozens of studies, but there's also, we've got basic knowledge about hormones work in the brain. So my big question really is why is it that so many women who are diagnosed with a mental health condition are prescribed antidepressants rather than hormones? And it's the same here, it's the same in your country, and it's wrong, really. But that's because so many women are scared. They think there are risks of taking hormones. So I just want to be really clear here that there are risks, but the risks are only with synthetic hormones. So these are chemical hormones that have been manufactured to made to work like hormones, but not the same. So this is a structure on the left of estradiol, which is the hormone that we produce ourselves. But in every single contraception, other than one, they contain ethinyl estradiol. So this is complicated. You don't need to really take it all on board, but I've put a circle around the chemical structure of estradiol. And all the others, you'll see, if you were playing Spot the Difference, you'll see they're all slightly different. And this is really important because they don't work in the same way. And that's a lot of people don't realize that. A lot of doctors don't realize that as well. That every single synthetic hormone in older types of HRT and in contraception are synthetic hormones. They're not the same as our own hormones. Whereas when we prescribe hormones now, we prescribe the natural estradiol, the natural progesterone, and the natural testosterone. And some people find it confusing to think about the difference. But if I was saying to you that you need to eat a bit more chicken, and I showed you a picture of both and said which one's got chicken in it, you'd probably be able to tell me that the real chicken contains chicken and the crisps just contain some synthetic chemical to act like chicken or taste like chicken. Not saying you can't have it, but it's important to know the difference. So the risks of clot, stroke, heart disease, breast cancer are all associated with the synthetic hormones that are actually in contraception rather than the natural body identical or bioidentical hormones we prescribe now. Testosterone is really important, and I know Joy's done a really great article about it. We've published data as well. In the UK, our guidelines say that we should really consider women with reduced sexual desire. But actually, there's lots of reasons why women have reduced sexual desire. But our research is really interesting because we know that testosterone can help with energy, help with stamina. This is one of our papers to show that a lot of people, as you probably realize, stop and reduce exercise because of muscle-related symptoms and menopause-related symptoms, joint pains, all related to low testosterone. And when we look at the symptoms, when we give back testosterone, it's really quite remarkable. If I told you there was a new drug that would improve fatigue, memory, and your focus and interest in things by that much, you'd say, give it to me now. The paper I just showed you before about physical activity and joint pain, we found that 73% of women felt that their testosterone helped increase their physical activity. It's a huge amount. And then I funded a PhD student in suicide prevention, and we found that women who were prescribed all three hormones, so progesterone, estradiol, testosterone, had a 92% reduction in suicidal thoughts. This is really, really important because I've said to you already, suicide rates increase. I've said to you already how we're over medicalizing people with the wrong treatments often. There's no psychiatric medication that will reduce suicide thoughts by 92%. 1 in 6 women we see in our clinic as new patients have suicidal thoughts. We also do a lot of deprescribing in our clinic, and we found that 26% of women using antidepressants or anxiolytics, actually, we could reduce them when we started them on hormones. There's always a debate about, are too many women having hormones? Are we giving the right dose and all of this? But in my mind, let's take a step back and look at the bigger problem. The bigger problem is globally, only 5% of menopausal women are receiving hormones. So 95% of women are putting their health at risk by not having hormones. And worse than that, they're being medicalized and misdiagnosed. And this is quite a dramatic picture, but it shows a landscape that I see and hear all the time, and we need to change it really. So going back to Laura, just to summarize really, Laura was a patient I spoke to you at the beginning about. She was prescribed estrogen progesterone and testosterone, all three hormones. And I also gave her vaginal progesterone, which is DHEA, so it helps with her localized symptoms. And when I saw her after 3 months, she said to me, I felt like I was sinking through quicksand and you have lifted me out. Thank you. And really important, she'd been involved in all the decision making and she left, she felt listened to. That's so important because she hadn't done before. And then just to remind you, Mary was a 22-year-old girl with having all those symptoms being considered for lithium. But she had PMDD. And so rather than giving her tablets, I thought about giving her natural hormones back because she was getting that drop, as you know, before her periods. So I gave her some patches to top up her estradiol because her estradiol level was low. And I gave her some progesterone just for 10 to 14 days when her symptoms started to be worse than before her periods. I gave her some vaginal progesterone because she was having awful cystitis as well. And after 3 months, she said, I thank you. I cannot believe the difference this treatment's made to symptoms and quality of life. So important that we think about it. Just before I end, I really want to think about the bigger picture because a lot of people say, well, is it just hormones to improve our health? I think hormones are so important because I've explained to you how they work in our body. But I can't just take hormones and expect my life to be as healthy as possible. I need to look at other things that I do as well. So I know a good doctor, I have my hormones balanced, but I also do headstands most days as part of my yoga practice. So I'm just showing this because it's a really nice straight one with one of my daughter's pictures in the frame. But we need to think about exercise we can do, nutrition, everything needs to feed together. But I tell you what, when I didn't have hormones, my joints were so stiff I could hardly do yoga at all. So we need to be incorporating everything together. So those people that tell you you can do yoga for your hormone change symptoms are wrong.
Yeah.
I'm also just mentioning balance, which hopefully you know it's been filmed in your country. Sadali and Anubhuti, the monks, came over to film me over there, and it's just been hopefully it's going forward for an Emmy now, but it's amazing. So you should all download and watch it as well. Balance Plus, just to let you know, is the paid for part of Balance where there's even more content. And we have to do this because otherwise we're not going to make any money. And I'm running it at such a loss and I don't want to close it. But we do weekly Q&As. We've put on Kelly Cashel and Jill Chimusky, who Jill is a phenomenal nurse from the US who works with us. Joe from the Cerebral Talk has talked about hormones and migraine. He's US as well. Lots of articles and then tools to help people when their doctors say no. So I'm going to end the conversation now just with a quote, just to think about how we can prevent disease and think about the life in your years, thinking about health span rather than lifespan. So thank you again, and I hope there's a bit of time for questions.
Yes, absolutely. That was wonderful. And I will tell you, when I'm keeping up with the chat, you've already made people cry just from the moment you started.
Oh, I'm sorry.
So it was really beautiful. You touched on a lot of different points that I think people don't know about hormones.
Mm.
So that was really, really powerful. I think let's just get into some of the questions. Um, Lori on here is saying that using testosterone gel every other day made her a raging animal, not in a good way. What do you suggest for best administration, or what do those?
Yeah, so it's really hard for testosterone, and I know in the US it depends on the states and the preparation. I don't tend to prescribe it where it's given every other day or twice a week. And lots of people are using a pump, doing it that way because then you get a super physiological, a high dose one day and then nothing the next day, and it can really make people out of kilter. So if you can get the testosterone sachets or compounded cream, it's so much better because then you just use a small amount every day. But it's also looking at the balance of your other hormones. Some people who have very low testosterone levels when they start it, it's like their brain is just waking up very quickly and people can get very angry and irritated and feel a bit highly wired. If that happens, just use a small amount and then gradually increase over the next few weeks.
Okay. And can hormones affect pelvic floor or make it better? It's a great question.
Yeah, so hormones when we don't have them can really negatively affect pelvic floor. A lot of people have urinary incontinence, so stress or urge incontinence. Prolapses are very common. Pelvic floor just become weaker. And we've got hormone receptors throughout our pelvic floor. So vaginal hormones, that's why I like progesterone or DHEA because it converts to estrogen and testosterone. We've got a lot of testosterone receptors on our pelvic floor. So, most women at any age, my two children who are, well, my two oldest are 23 and 21, they both use vaginal hormones.
Oh,
One
wow.
because of recurrent thrush she was getting, and the other one is because she was getting recurrent UTIs. So anybody of any age can use vaginal hormones.
Oh, vaginal. Okay, that's very interesting. And I feel like
Yeah.
that's, again, you
Mm.
really pushing outdated assumptions there because
Yeah.
I don't think that's very widely, known or accepted at this point.
No, it's not because people don't think about it because everyone just thinks that it's just for old people who have urinary symptoms, and even then they don't. I mean, if you think 90% of women have those symptoms and less than 10% have vaginal hormones, but because younger women, especially if they're on contraception, it blocks their hormones working naturally, so they're more likely to have UTIs, more likely to have, vulvodynia, pain on intercourse, all of that, and they should be thinking about vaginal hormones.
So interesting. Do you have a view on different types of testosterone available? I think this is maybe someone from the UK. I don't even recognize all the different the brands there.
Yeah, so I mean, I usually in the UK I only really prescribe Gel sachets, which are the gel sachets, or Androfen we can get over here, which is the female testosterone that's licensed from Australia, or we can get it compounded, so made as a special for people, which is great. We're doing it more in the clinic because you can do it as a pump, so you can really measure the dose. And if some people need slightly more because the absorption's not great, we can make it more concentrated or if they need less, but then it's a lot easier to use.
Mm. So someone, this is so common from Portugal, is saying it's so hard to find a doctor.
Yeah.
Is there some sort of database where you could bring, point someone to? And I think the answer is no, but I just said earlier, I'm like, bring a study, bring some of this information from Dr. Newsom to your doctor if you really know what you
Yeah.
like it'd be
So
helpful,
I
right?
think, yeah, I mean, we've got our Newson Education, which newsoneducation.co.uk. Share that with your doctor so they can get educated. I'm really cautious recommending different clinics and practices because things change a lot. Doctors come and go, people change. We want to make sure that they work out of evidence, but it's often asking other women, actually. I mean, we see a lot of women that fly into our clinic from Europe and then, just come every so often and go back with a suitcase load of hormones. I mean, it's terrible, but I can't tell you that any country is good because they're all shocking.
Mm. What about hormones when you're before dealing with an autoimmune disease? Do you need to work on one versus the other first?
No, so I would look together. So autoimmune diseases are so much more common in women. They're more common in women in their 40s, and so are hormonal changes. And I've written a lot about it in my book. And we need to be thinking about it slightly differently because they help our immune system so well. A lot of people are given biologics or steroids, but actually, if you can get those macrophages working better, boost your immune system naturally with hormones, testosterone is really important as well. So it's but you can still have other treatments as well. It's not like the synthetic hormones that you have to be careful of interactions with other medication. Actually, you can all take natural hormones with any sort of biologic or any other medication.
Mm. Here's a more technical question about, progesterone, talking about how it's protective in the uterus versus oral, or, do you recommend oral or vaginal, and which one protects against that abnormal uterine bleeding?
So it all varies. It's all about absorption at the end of the day and metabolism as well. So a lot of gynecologists seem to get very scared about women who bleed, whereas most women, if they're feeling well, they're not really as scared as their bleeding as their mental health or whatever symptoms they've had before. So often start off with the oral micronized progesterone, but again, absorption can vary between women. We use quite a lot of pessaries and suppositories of progesterone as well, especially people with PMDD. It can make a big difference. We have people that have a lot of bleeding, but it's also looking at the balance of the estradiol dose as well, because some people, if their dose is too low or they're not absorbing properly, then they can almost destabilize the lining of the womb and then cause more bleeding as well. So, but we always try and give natural progesterone rather than giving a synthetic progesterone will help bleeding a lot more because that's how what it's been designed to do is to stop bleeding, stop the wound building up, but it gets into the body and then it has negative effects. So try to avoid them if we can.
And then anything you do vaginally, is that estrogen or progesterone or testosterone, DHEA? Does that absorb systemically or does
So
it
it's
stay?
a good question. So the DHEA and the vaginal estrogen preparations are very low dose, so they just work locally. The vaginal progesterone and the rectal progesterone, we give at a higher dose, so then they go through the mucosa into the bloodstream and then affects every cell and tissue in the body. The progesterone is to get into the body. The others are just to work locally.
So it's really about dose. So if you're trying to get it
Yes.
systemically, then it's a higher dose there. Okay, that makes sense. When do I do testing and I have two doctors. Should I share the results to both doctors?
Yeah, you can do. It's really difficult actually because a lot of laboratories say results are normal when they're not. And so you really need to have your blood tests interpreted with someone who understands you as a person, but also what hormone levels are, because there are limitations with some hormone levels as well.
Mm. How about do I need testosterone? If I'm taking estrogen and progesterone, do I need to add it? I have had a hysterectomy.
Okay, so you're still in this morning. Depends which country you're listening. In the UK, it's 4 o'clock in the afternoon. But this morning at 9 o'clock, I did a live Q&A about testosterone, which is now on my YouTube. So if you go to my YouTube, look at today as a Q&A about testosterone, and that will answer lots of questions about testosterone for you.
Great, great. And then do you have any suggestions for help with waking earlier than normal, anxiety, overwhelm? Yep.
Yeah, it's very common. So our hormone levels naturally are at their lowest about 3, 4 in the morning, where that's when we usually wake up and we just have all these catastrophic thoughts and our mind's racing and everything else as well. So balancing hormones, progesterone is very calming. If we take it orally, it gets metabolized to allopregnanolone, which really helps with sleep. But a lot of people find taking it as a pessary or some people use it as a cream. I've had a hysterectomy and I use progesterone as a cream, so I'm not using it for my womb because I don't have one, but it helps with my migraines and helps with my mood and it definitely helps sleep. Magnesium supplements can also help as well. I mean, I meditate quite a lot just to clear my mind because I have so much going on in my mind. So it's not all hormones, but definitely all three hormones balance really can help sleep.
Mm. How about this is always a tough subject, hormones after cancer, breast cancer. Uh,
Yeah.
that's
So, thanks for mentioning it. So, after most cancers, absolutely fine. Lots of doctors are very scared, but that's because they're scared anyway, really. One of the things really to remember is that whether someone's had cancer or not had cancer, there are still many benefits from hormones. So, a lot of people take hormones. For example, one of my things I'm really scared about is osteoporosis. So, one of my reasons for taking hormones is to reduce my incidence of osteoporosis. Whether I've had cancer or not, I've still got an increased incidence of osteoporosis when I don't have hormones. So denying someone blanketly hormones because they've had cancer means they're putting their future health at risk. But it's not just about estrogen. So the concern is always if someone's had an estrogen receptor positive breast cancer. But let's think about it. There are different hormones, and some people who we see who've had breast cancer, we might start with testosterone on its own, and a lot of people find their symptoms really improve. But there's never been any studies that show that any of the three hormones, progesterone, estradiol, or testosterone, worsen outcome when they're given to women who've had breast cancer. Some women I see in my clinic have had breast cancer 10 years ago. A woman recently said, I would prefer to go through breast cancer again if it meant that my brain would work, if it meant that I didn't have joint pain, if it meant I could sleep through the night. So it's a very individualized choice, but we've done it. There's a lot of work on Balance Plus. So if you go to Balance and subscribe to Balance Plus, we've got a lot of videos as well. Susan Hardwick Smith is a US doctor who's brilliant. She's done some videos for us, Jill Shamoski as well. And we've got articles for women specifically who've had breast cancer. So I urge you to just download it and really get a lot of information from there because it's a big topic. And a lot of doctors I know who specialize in breast cancer tell me that they just say no to women because it's easier, Louise. We're scared of hormones, so it's easier to say no. Well, it might be easy for them in the consulting room, but it's not easy for the women who leave their consulting room and are struggling with symptoms. And all women who've had breast cancer, there's no reason why they can't have vaginal hormones as well.
Oh yeah. And I can tell you from a perspective of someone that owns a clinic and has, doctors and nurse
Mm.
practitioners prescribing hormones. I think, our people always want to help the woman, but it is scary because, breast cancer or other cancers will happen to a certain amount of the population,
Yeah.
right? And no, and it's scary to go, well, will my license be
Yeah.
fine if that
Yeah.
happens and we blame
And
hormones, right?
so it's really interesting. When I started my clinic, I was on my own. So I was very, very exposed because I was just on my own. I had no, now I've got a lovely executive team. We've got lots of doctors. But the first patient that I prescribed hormones to, I literally couldn't sleep. She'd had breast cancer a few years before. She came to see me. I was so worried that I'd given her some hormones. She came back for her review and she was like, "You've given me the best life ever. I feel the best I felt for years." I was like, "Oh my goodness, you've given me the worst life ever. I've been so worried." And then one of my colleagues who's now retired, she came to talk and said to me, and she'd had breast cancer herself. So for many years, she'd been prescribing hormones for women who have breast cancer. And she said, Louise, I ride bareback. I love horse riding. She said, I go up all these mountains. I don't always wear a helmet. None of my oncologists have ever stopped me doing that. There's no doubt about it. That horse riding is far riskier than me taking hormones. But what I'm doing is I'm choosing for myself. So we have a shared decision making document that we offer for patients to write to sign. It's not a consent form, but it's basically saying we've had a really lovely discussion. We understand there are benefits of taking hormones. There might be risks, but they're very theoretical because there's nothing in the data. But I understand and I want to, try those hormones. And a lot of women I say to, if you try them, and then in 3 months' time you don't feel any different, you don't have to continue them. Make your decision after 3 months as well, because then it's easier to know how you're going to feel. And it's really hard. We have had patients because we've got a big practice who have then developed breast cancer and they've been taking HRT. And again, the first time that happened, I was like, oh, here's the gun. Where's the lawyers? What's going to happen? But actually, women know they might have a car crash. They might fall down the stairs. That's not going to be related to taking hormones. 1 in 7 women get breast cancer. And actually, over the years of us doing the clinic, less than 1 in 7 of our patients get breast cancer. So, we women are quite sensible, really. So no one should be pointing a finger or doing a lawsuit because someone's had breast cancer. It's because, the risks are with the synthetic hormones. So we should be more scared of taking the contraceptive pill than taking natural body identical or bioidentical hormones.
At that point, though, do you take the woman off of any hormones when she's diagnosed?
So again, it's very individual. I've got one patient, Trudy, who I've done a podcast with. If anyone wants to listen, you can just search Trudy, and my name. She had a very, very aggressive form of breast cancer, and she was suicidal before she'd had hormones. I gave her hormones, then she developed breast cancer about a year after, and then her oncologist said, you know what, we're going to give her such strong chemotherapy and we're going to do a mastectomy, that having the small amount of hormones you're giving her is not going to worsen her outcome. And now 10 years on, she's doing really well actually. But we work in conjunction with people. Some people stop it, or they might just continue the testosterone. It's all very individualized.
Okay. Yeah, that makes sense. What about tamoxifen, that is something that blocks estrogen, is
So
that right?
tamoxifen is a selective estrogen receptor modulator, so it's partially blocks the action of hormones on the breast, but elsewhere in the body it can increase estrogen, including estradiol as well. A lot of people don't actually know exactly how it works, but we do sometimes give hormones with tamoxifen as well. So again, it depends on the individual situation, really.
One more, and this, I wonder what this is progesterone only for women that have gone through menopause, or can we use it during perimenopause?
Yeah, so you can use it at any age. Progesterone is the vaginal DHEA, which converts to estrogen and testosterone. It's a daily pessary. I use it first line for patients instead of vaginal estrogen because it's so much more effective. But younger people can use it. So anyone that has recurrent UTIs, anyone, this sounds a bit weird, but anyone who's aware of their vulva and vagina when they're just sitting down, you shouldn't be. So if you are, then that you might have some changes there related to hormones. People with any pain or discomfort, bladder problems, really they should be first line
Mm,
treated.
okay. You mentioned the synthetic hormones that we should be more worried about, those in
Yeah.
cancer, and I'm curious what your recommendations are for younger women who do need to be on birth.
Yeah, so I think about this a lot. I've got three daughters, so I think about it a lot. So I can, they don't mind me telling you, but my oldest daughter has a Mirena coil in, so an IUS because she has heavy periods. She tops up with all three hormones. She has PMDD as well, so she has quite a high dose of progesterone as a pessary, actually, which helps her PMDD, and she uses estradiol and testosterone because the Mirena can often block, it can stop ovulation. And so that means if you're not ovulating, you don't have hormones. So she has all three hormones added back. My
Mm.
middle daughter uses Zoli. I don't know if you have that in the US. It's a synthetic, contains a synthetic progesterone, but it contains estradiol because all other combined oral contraceptives contain ethinyl estradiol, which is a synthetic hormone. But she also, my middle daughter also uses progesterone and testosterone as well because her testosterone was low. So she tops up with natural hormones. And then my youngest daughter doesn't need contraception, but she has heavy, painful periods. She's a teenager. So she just is prescribed some progesterone orally. So natural progesterone, the micronized progesterone. So her periods are lighter, they're less painful. It's a lot safer than having synthetic hormones.
Is that more common in the UK than it is in the US?
No.
Yeah,
Yeah,
okay.
and no, no, but the thing is, what's really interesting, there was a doctor called Dr. Katrina Dalton that qualified in 1948. So in the 50s and 60s and 70s, she was prescribing a lot of progesterone to people, but people didn't really like her in the way that some people, I guess, don't like me because they were all trying to promote the synthetic hormones. But she was very clear the natural progesterones are better and safer, which she was right. So we've reactivated a lot of her work in the clinic, and you see the results. But we also need to remember for women is that there are non-hormonal methods of contraception. Obviously, there's barrier methods, but there's the copper coil as well. So, it's not all about having a synthetic hormone all the time.
Yeah, interesting. I know we're running late. I think I have one more question. There might be a couple more in another spot. Um, does HRT, this is about skin, elasticity, cell renewal. If you can talk a little bit about what happens in menopause and why HRT may or may not.
Yeah, so our skin is one of our largest organs in the body. Everyone thinks it's just a cosmetic thing that we look better if we take hormones. But actually, if our skin looks better, then our internal organs, our kidney, our liver, our lungs, our heart are going to be better as well. And so we lose a huge amount of collagen before our period stops, especially in the perimenopause. And if people have got more wrinkles on their face and less collagen, they're going to have less collagen in their bones as well. So more osteoporosis. There's this whole thing that we shouldn't just take hormones for our skin, whereas actually our skin is a window into our bodies. So it is important to think about looking after our skin, but I don't just mean our face. I've done a podcast recently with Dr. Sad Rajpal, a fantastic dermatologist, that came out recently. So I would have a listen to his podcast with me. And we talk a lot about the role of hormones on the skin. I know a lot of people are putting vaginal hormone preparations or compounded low dose estradiol or estradiol on their face to help reduce wrinkles and everything, which is, I don't have a problem with it, will help topically on the skin that you're using it. But we shouldn't be using it instead of systemic hormones because we want all our skin to be healthy, not just on our faces.
That really puts meaning to, healthy and glowing from the inside out.
It does indeed. Yeah.
Start there. Okay, I lied. I'm going to ask you one more question because we get this one all the time because we really do a lot of testing and have from the beginning. And it's funny because I remember when we started 5 years ago, I got a lot of hate online for like you're testing just to make money and you can't test for hormones because they fluctuate. So um, Tilly is asking, how do you test accurately for hormones because they do fluctuate throughout?
Yeah, so it's really important. There's a few things. The first thing is it's really important that you don't just do a test and read it your results yourself. There's a lot of AI generated results now that are coming out with comments, and I've seen quite a few where they've said the results are normal and they're not, the levels are low. So just really be careful who's interpreting those blood tests. Also be really careful. We work really carefully with our laboratories. We know them really well. We've tried with other laboratories and the results are not as good because they use different reagents, they have different processes. So it's important and it's hard to know that. The pinprick blood tests are going to be different to venous samples as well. So again, you can get spurious results. And then if the blood tests are low, it can be useful. If they're normal and you think your symptoms are related to hormonal changes, don't be put off by a normal blood test because it was only normal the time that you had that blood test taken. 10 minutes before, 10 minutes after, it might be completely abnormal.
Mm.
Even when you monitor hormone blood tests with someone on HRT, the levels can really change as well. And I've did my own blood test. Well, I got someone to do it 10 times in a day, venous samples. And I've been on the same dose of hormones for many years. And it's interesting because time of the day, my testosterone level is slightly high, another time it's slightly low, and there's a range in between. So if I'd seen a doctor when it was high, they would have gone, oh, reduce your dose. If I'd seen a doctor when it was low, they would have said, oh, increase your dose. Well, I didn't need to do anything because I'm feeling fine. So we
Mm.
need to just take it in context as well, blood tests, but they can be useful. They build up a picture and a story for us.
Yes, absolutely. When we have, especially when women are on testosterone, it's a controlled substance. We like to monitor several
Yeah,
times throughout the year, and then it does help complete a picture.
of course it does.
Yeah. And what I always find interesting too is, we don't just test for the sex hormones because, there's so many other markers that mean
Mm,
something for a woman
yeah.
going through this phase too. So it's always interesting for me whenever I test to see what's changed and it informs me of maybe what else I need to work on a little
Mm,
bit. And I think it's a journey. There's always something, and things change. So it's important to keep monitoring and keep checking in with someone on your symptoms and how you're feeling because
yeah.
even if you can get steady for a long time, but then,
Mm,
seasons change and so always listen to yourself because you really know
absolutely.
how you should feel, right? Well, I thank you so much. I know we're out of time. I really appreciate everyone. Louise Newson, you are such an
Oh, thank you
inspiration,
so
and
much.
thank you so much for taking the time to be with us
No,
today.
well, thank you for inviting me.
Yes, we will send this out to everybody who registered so everyone can do a replay and we'll post that.
Great. All right. Thanks so much,
Thank you.
everyone. All
Have a great
right. See
weekend.
you. And you. Bye bye.